All right. Hello, everybody. Welcome back. My name is Robert Lasco. I am an emergency medicine clinical pharmacist at the Washington Health System in Washington, Pennsylvania. And this is MedMinded Consulting's Empiric Antibiotic Therapy by Medication this time, Part 1, the beta-lactams, just because the beta-lactams are such a big category, so they get their own video. So let's start off with the basics, penicillin G and penicillin V. So essentially, Pen V is the oral formulation, and penicillin G is parenteral, so it'll go IV or IM. In terms of important coverage, Pen G and Pen V will cover most strep, it'll cover enterococci, and it'll also cover your treponema pallidum, so that is your syphilis. And then in terms of important use cases for penicillin, the regular penicillin, you could do group B strep within pregnancy, dental infections, and prophylaxis. Mainly prophylaxis. We don't see too much treatment of periodontal infections with penicillin. And then you can also use it for very simple strep pharyngitis, and then it is the mainstay of therapy for syphilis, so that's your treponema. And then some important facts about penicillin. It has a very short half-life, so it has frequent dosing, usually QID. Then there's Pen G, benzathine, is IM only. If you give it IV, you will kill them. And then Pen G sodium is your IV formulation, as opposed to Pen G benzathine. So the benzathine is more of a local anesthetic. And you know what happens when you could give lidocaine or something similar IV. You could cause them to go into a ventricular tachycardia and die. So that wouldn't be good. Next up is the aminopenicillins. We have amoxicillin, which is PO, and then we also have ampicillin, which in America at least, it's generally IV, but you could also give it PO, but we see it more commonly IV. So these have more gram-negative coverage than regular penicillins. Important coverage in terms of the aminopenicillins, you still have strep, you still have enterococci, you add Haemophilus influenza, which is great, and then you get your enteric gram-negative rods. So important use cases for this, dental infections and prophylaxis again, but this time they could actually be used for treatment of periodontal infections. They're also used usually second line for Lyme disease, community-acquired pneumonia, again your simple strep pharyngitis, occasional UTIs, and then some skin and soft tissue infections. So some important facts. They still have a pretty short half-life, but they're also very susceptible to beta-lactamases, which is not great, especially in this era of increasing bacterial resistance to antibiotics. So aminopenicillins and penicillins are the beta-lactams that should come to mind for enterococci. No cephalosporins cover enterococci, so that's like your Enterococcus faecium or faecalis. These are important for combating those organisms. All right, next we have anti-staph penicillins. You've been seeing these probably less and less commonly as we have fallen more into the MRSA age. But this is your oxacillin, nafcillin, methicillin, dicloxacillin, and cloxacillin. Most institutions have, a preferred anti-staph penicillin. At our institution, I want to say we use nafcillin, but it's so rare that we really use it. These are modified to be more resilient to the beta-lactamases, and in terms of important coverage, they get staph and strep. Again, these are your anti-staph penicillins, so very, very good at killing MSSA. MSSA, of course, being methicillin-sensitive Staph aureus, and that comes from the drug methicillin. So, important use cases, endocarditis. That's probably the biggest one that we see nowadays, at least at my institution. I'm not sure if it's different, around the country or around the world, but endocarditis is the big one. Those are like the 24-hour drips of oxacillin, nafcillin, or methicillin, literally just going around the clock. And then you also have skin and soft tissue infections, but at least in terms of my area, these have largely fallen out of favor, osteomyelitis, and prosthetic joint infections. So some facts, like I said, largely fallen out of favor. Not sure how that trend tracks across the country, but at least in my area, at several institutions, I hardly ever saw them. These do not cover enterococci, so that's really important. They have poor coverage of pretty much anything except staph and strep, hence why they're called anti-staph penicillins, and they're used primarily for endocarditis as a 24-hour infusion. at least in my institution. So next up is penicillin and beta-lactamase combos. This would be ampicillin-sulbactam, amoxicillin-clavulanate, and piperacillin-tazobactam. So two of these you could kind of group together, and then one usually stands alone. So the addition of the beta-lactamase inhibitor makes it more difficult for bacteria to break down and inactivate the antibiotic. It's really important to note that these usually do not add any additional bacterial coverage. So these are bacteria that would be covered anyway by the ampicillin, the amoxicillin, or the piperacillin. The addition of the beta-lactamase usually does not add any sort of antibacterial element. So some important coverages: you retain your staph, strep, enterococci, anaerobes, enteral GNRs, and you also, for pip/tazo, you add Pseudomonas, which is really important. In terms of important use cases for Augmentin or Unison, I tend to employ them for less complicated intra-abdominal infections like diverticulitis or infectious colitis. Also use them for UTIs, community-acquired pneumonia, dental infections, otitis media, diabetic foot wounds, and animal bites. Animal bites being important because they cover the Pasteurella that can come about from animal teeth and animal mouths, so very important. So some facts: still very effective for enterococci, and they're more viable for gram-negative rods and anaerobes now, just because they're less susceptible to the beta-lactamases, and at least in terms of the Unison and Augmentin, they're very widely used. So more on the Zosyn side of things, important use cases. We still have intra-abdominal infections like diverticulitis, but we can also add some more serious sorts of intra-abdominal infections like appendicitis, cholecystitis, etc. Still very viable for UTIs, also hospital-acquired pneumonia, ventilator-acquired pneumonia, sepsis, skin and soft tissue infections, and diabetic foot wounds. So some facts on Zosyn: still effective for enterococci, more viable for the gram-negative rods and anaerobes. Very, very wide spectrum of use, though please consider the fact that we need to reserve this antibiotic just because MICs are creeping up. So it does have wide use cases, but you should still reserve it for only when needed. And when combined with Vanco, you have a risk of increasing serum creatinine. They used to think you would progress to renal failure when combined with Vanco, or at least an increased risk. But there have been some recent studies that show no significant difference in progression to hemodialysis, which is your endpoint. So take that how you will. So use may be tempting, but please reserve it for when it's needed, just in order to preserve it for patients who really, really need it. Getting into your cephalosporins, the first generation cephalosporins, you have cephalexin, cefazolin, and then there's also cefadroxil, which I've never seen used once. These are some of the most widely used meds in the hospital. And in terms of coverage, they cover staph, strep, and they have some elements of gram-negative synergy with enteral gram-negative rods. Those have been recent studies showing the potential for gram-negative coverage, so that's been pretty interesting lately. In terms of important use cases, you have skin and soft tissue infections, surgical prophylaxis, UTIs, osteomyelitis, endocarditis, and possibly some use with that gram-negative synergy in intra-abdominal infections. I mean, it's honestly so hard to pick a use case where you see it more than, another use case. They're just used all over the place. They're wonderful drugs. 10 out of 10 would recommend. And then in terms of some facts, extremely common for surgical prophylaxis. There's Ancef, and then you start getting into a third generation cephalosporin, or maybe vancomycin if they're penicillin allergic, which I disagree with, but whatever. Those are like the mainstays of surgical prophylaxis. These cephalosporins are dosed less frequently, which gives them an advantage over your basic penicillins and aminopenicillins. But do note that cephalosporins do not cover enterococci. These do not cross the blood-brain barrier, so that's extremely important to remember. Now your second generation cephalosporins, you have cefuroxime, cefoxitin, which I see a lot more than cefotetan, cefprozil, or cefaclor. It's really dependent on your area. So as we advance through the generations, this lessens your gram-positive coverage to a degree, but it does enhance your gram-negative coverage. In terms of things that these cephalosporins cover, you still retain staph, strep, and enteral GNRs, but you also add Haemophilus influenzae, Neisseria species, and anaerobes, which is restricted to cefoxitin and cefotetan. And then in terms of important use cases, still use them a lot for community-acquired pneumonia. And then you will see cefotetin and cefoxitin for surgical prophylaxis, usually intra-abdominal surgeries, sometimes like a lap appy or cholecystectomy, something like that. And then some fun facts, they're not really used as much compared to the first and third generation cephalosporins just because they kind of fall in an in-betweener category. And then cefoxitin and cefotetin are becoming more used due to the anaerobes and GNR coverage. Next up, we have the third generation cephalosporins, including ceftriaxone, ceftazidime, cefdinir, cefpodoxime, and cefixime. They offer great gram-negative coverage, but much less staph coverage, so not as great as a targeted agent against MSSA, but in terms of important coverage, you do have MSSA on there, just not as bactericidal as some of the earlier generation cephalosporins. You also get strep, with the exception of ceftazidime, which has poor coverage, enteral, gram-negative rods, and then ceftazidime makes up for its lacking strep coverage because it adds Pseudomonas coverage, so that's pretty great. In terms of important use cases, we have community-acquired pneumonia, pyelonephritis, meningitis, sexually transmitted infections, particularly gonorrhea, Lyme disease, and hospital-acquired infections. So some important facts to know. Ceftazidime is pretty much only attractive for the treatment of pseudomonal infections. Ceftazidime and ceftriaxone do cross the blood-brain barrier, so it makes them great for meningitis, but do remember that ceftazidime lacks very good strep coverage, so strep pneumo is a very, very big cause of meningitis, so that does not make ceftazidime a very attractive option for empiric meningitis treatment. But ceftriaxone has great coverage of strep, so that's why we use it for meningitis. And that's pretty much the only time you'll do the 2 grams Q12 hours is in meningitis, which also makes it kind of like a fan favorite, at least for me and the providers that I work with. Ceftriaxone can be used for pretty much anything. It's pretty great. So we use it quite a lot, especially pyelonephritis nowadays, just because our fluoroquinolone resistance rates are greater than 20%. So that kind of takes them off the table for empiric use and puts ceftriaxone in the driver's seat. And also remember that in neonates, ceftriaxone can force calcium crystal precipitation, which can cause multi-organ failure, which is bad. Risk factors for that, it is a newborn less than 28 days old, or hyperbilirubinemia. That makes it an absolute no-go, just because ceftriaxone has that dual renal elimination with the biliary tract conjugation. So it makes it attractive because you don't have to renally dose it, but in neonates, you're at the risk with hyperbilirubinemia, so that's not a great idea. Your fourth generation cephalosporins, that would include cefepime only. They have great gram-negative coverage. Gram-positive coverage is somewhat decent. They're kind of, mixed. And then in terms of important antibacterial coverage, you have strep, enteral GNRs, MSSA, Pseudomonas, and Acinetobacter, which makes it very, very viable for hospital-acquired pneumonia and ventilator-acquired pneumonia. And then you also could use it for sepsis and febrile neutropenia. So some facts about cefepime: it's very useful for those drug-resistant hospital-acquired infections. It is, quote-unquote, less nephrotoxic with vancomycin compared to zosyn, even though, like I discussed earlier, it's just really, the vanc-zosyn combination really just increases serum creatinine, no significant progression to hemodialysis, so that's questionable. But it may produce neurotoxicity like the other beta-lactams, so make sure you renally dose your cefepime. So your fifth generation anti-MRSA cephalosporin would be ceftaroline. It's the only cephalosporin that covers MRSA, and then it also has gram-negative coverage about equivalent to ceftriaxone. So some important bacterial coverage, you get strep, enteral GNRs, MRSA, and you also add Enterococcus faecalis, which is amazing. It's the only cephalosporin that's going to cover Enterococcus. And I know I said no cephalosporins cover Enterococcus, but ceftaroline is not your normal cephalosporin. So important use cases, community-acquired pneumonia, and then also MRSA, skin and soft tissue infections. So some fun facts: it was engineered specifically to bind to the domain of MRSA, unlike other beta-lactams. So that's why, it's kind of like a designer drug, but not in your PCP or ecstasy sort of designer drug way. It's in your MRSA coverage, safe humanity kind of way. And like I said, it's the only cephalosporin that covers Enterococcus. It does cover faecalis, but not faecium. So keep that in mind. So next up, cephalosporin and beta-lactamase inhibitor combinations. You have ceftazidime with avibactam, which is Avicaz. and ceftolozane with tazobactam, which is Zerbaxa. These are extensive gram-negative coverage agents. They are extremely expensive compared to other antibiotics, but they are reserved for MDR infections. So in terms of important coverage, you get Pseudomonas and enteral GNRs like Klebsiella. And then for important use cases, they're used for multi-drug resistant pseudomonal infections and then extended spectrum beta-lactamase infections. So ESBL infections are becoming a big problem. So it's pretty much, it's between, a carbapenem, but if they're carbapenem resistant, you might be able to use one of these. So facts, they provide coverage for your extremely multi-drug resistant organisms, and then Avicaz covers for carbapenem resistant gram-negative rods like Klebsiella and Enterobacteriaceae. But these offer no anaerobic coverage, so not entirely useful by themselves for intra-abdominal infections. But then again, I don't personally know of any intra-abdominal infections with extremely multi-drug resistant organisms. Usually it's like more of an upper respiratory or urinary tract infection with like something like Pseudomonas or Klebsiella. Maybe some Serratia marcescens, but whatever. Next up, carbapenems. So these are your mainstay of therapy for your extended spectrum beta-lactamases. We have meropenem, doripenem, imipenem with cilastatin, and ertapenem. So these are very broad spectrum agents. The meropenem, doripenem, and imipenem with cilastatin coverage is very different than ertapenem. So in terms of important coverage for all of them but ertapenem, they cover anaerobes, MSSA, strep, enteral GNRs, Pseudomonas, ESBLs, Acinetobacter, and Enterococci, which is great. And then in terms of important coverage with ertapenem, they cover anaerobes, MSSA, strep, and ESBLs, so you lose your Pseudomonal and Acinetobacter coverage. Important use cases for these is your hospital-acquired pneumonia, ventilator-acquired pneumonia, febrile neutropenia, ESBLs, intra-abdominal infections, and infections by multi-drug resistant organisms. And then some facts about these. Imipenem is nephrotoxic when it's metabolized, so that's why they add cilastatin, which blocks the nephrotoxic metabolites, so they're always paired together. You will never see imipenem by itself. Ertapenem is missing a lot of important coverage, but it did have an advantage because it's only dosed once a day. Personally, I could care less about that, so just immediately forget it. Renal dosing is required for these agents, so keep that in mind. Imipenem has the highest propensity to cause seizures out of these drugs. And then meropenem, you'll also see this sometimes combined with Vaborbactam for the extended coverage of MDR organisms, and that's called Vabomere. Personally, we are a meropenem facility. I don't know. Just depends on what your institution likes the best. As long as it's not ertapenem, because ertapenem sucks. Monobactams. This is aztreonam. So aztreonam, monobactam, it adds great gram-negative coverage, which includes Pseudomonas, gram-negative rods, and Acinetobacter. So important use cases for this, any type of gram-negative infection, especially for patients with a beta-lactam allergy. So let's say they claim that they get a rash and shortness of breath to penicillin. It is probably still okay to use aztreonam. Do not take my medical advice at this time, just because, I don't want to be held liable for when someone anaphylaxis to aztreonam, even though it's extremely unlikely to happen. So it is safe to use with a beta-lactam allergy, unless that beta-lactam allergy is to ceftazidime or ceftolozane. But if somebody can name that they have an anaphylactic allergy to ceftazidime or ceftolozane, I will eat my shorts. But it's because these have the same R1 side chain to aztreonam, and the R1 side chain is the most likely portion of the drug molecule to cause allergies. So if you want to look and see if your penicillins or cephalosporins have some sort of allergic cross-reactivity to your patient's allergy, just look up a chart on R1 and R2 side chains. And usually if the side chain is different or they're not in the same category, they're probably safe to use. And then aztreonam can also be inhaled for bacterial suppression in cystic fibrosis patients. So they nebulize it, goes directly to the site where they're colonized with bacteria, and then it kills the bacteria locally. So it's great. Kind of like tobramycin in that regard, nebulized and just acts locally. So I want to thank you a lot for watching. Feel free to email any questions to that email address or comment any questions or feedback below. This is Robert Lasko with MedMining Consulting. Thank you so much. Have a great day. See you in the next video.